Hi, my name is Ty Gluckman. I am a non-invasive cardiologist and medical director of the Center for Cardiovascular Analytics, Research and Data Science at the Providence Heart Institute at Providence St. Joseph Health in Portland, Oregon. On this episode of Clot Chronicles, I will be discussing the recently published 2020 ACC Expert Consensus Decision Pathway for Anticoagulant and Antiplatelet Therapy in patients with atrial fibrillation or venous thromboembolism undergoing PCI or with Atherosclerotic Cardiovascular Disease. This article was recently published in late December of 2020 and really was meant to help support clinicians in the challenging issue of what do you do with patients who may have varied indications for antithrombotic therapy. Specifically, we identified four key groups: a patient with atrial fibrillation receiving an oral anticoagulant who now needs percutaneous coronary intervention and thus antiplatelet therapy, a patient on antiplatelet therapy for atherosclerotic cardiovascular disease with new onset atrial fibrillation that now requires an oral anticoagulant, a patient with prior venous thromboembolism receiving anticoagulant therapy who now needs percutaneous coronary intervention and antiplatelet therapy, and lastly, a patient on antiplatelet therapy for atherosclerotic cardiovascular disease with new venous thromboembolism that requires an anticoagulant. And the challenge for me, and the challenge I know for all of you, is how do we balance antiplatelet therapy indications with anticoagulation indications to arrive at the best possible antithrombotic combination in order to mitigate the risk of thrombotic events without engendering increased bleeding risk. This is one of the key figures from the manuscript, but it really highlights the four scenarios that I just discussed and takes you through a stepwise process of reviewing clinical factors. What's the condition that's warranting anticoagulant therapy? The medication types, are they on an anticoagulant? Are they on antiplatelet therapy? And then in some cases, their need for PCI. And we cover this from the perspective of those that are in the acute care setting in the hospital, but also in the ambulatory setting. And then longer term, what should we be doing post-discharge? There are a number of helpful figures that I'll walk through briefly that really try and tee up a flow diagram or an algorithm to guide clinicians through the decision-making process. And while these look rather busy, in general, the themes are largely the same. As an example, this is the flow diagram for a patient with atrial fibrillation on indefinite oral anticoagulation who now needs PCI. And importantly for this document, we reviewed this from the context of people who are on a vitamin K antagonist or a direct oral anticoagulant, and then ultimately walk people through the steps necessary to consider both pre-procedurally, post-procedurally, and then in follow-up for longer-term discharge. We do a deeper dive in the hospital looking at people who are presenting based upon the status of their PCI. Are they coming in for elective or urgent PCI? And in the case of elective PCI, can things potentially be postponed? In the case of emergent PCI, that's not an option. And how do you, for people on a vitamin K antagonist or a DOAC for pre-existing atrial fibrillation or venous thromboembolism, how do you manage those anticoagulants? How do you manage antiplatelet therapy? Again, pre-cath lab arrival, during the cath lab procedure, and then ultimately early PCI period after they've completed their procedure, transitioning to the discharge period. This is actually the flip of that. What do you do for patients who are chronically on antiplatelet therapy who now come in with a diagnosis of atrial fibrillation? So it walks people through an assessment of, do they in fact have an indication for oral anticoagulant therapy? And if they do, what is the underlying driver of their indication for antiplatelet therapy? Was it being used previously for primary prevention? Do they have stable ischemic heart disease but no prior acute coronary syndrome? Do they have a history of acute coronary syndrome and whether they've actually received PCI or not? Do they have a history of cerebrovascular disease or do they have a history of peripheral arterial disease? And it walks people systematically through how to actually follow the transition from, in this case, someone who may have been on antiplatelet therapy that now may need to be combined with an oral anticoagulant therapy, or in fact, maybe someone can come off their antiplatelet therapy altogether and just remain on an oral anticoagulant alone. We also come at this from a perspective of those who have had prior venous thromboembolism. And while one may think that there is a lot of overlap, and in fact there is, there are unique differences for those individuals with venous thromboembolism insofar as many of these individuals will not necessarily require indefinite oral anticoagulant or anticoagulant therapy. This breaks it down from the perspective of, are they undergoing elective, urgent, or emergent PCI? And if so, how do you make decisions about initiation of anticoagulation overall? And then ultimately, if they have elective PCI and they have a time-limited duration of anticoagulation, can their elective PCI in fact be deferred altogether? We go a bit deeper in looking at people who have had venous thromboembolism on time-limited anticoagulation on the top portion, those with venous thromboembolism who now require indefinite anticoagulation and have undergone PCI in the bottom, and really review this in great detail, covering the various scenarios that you may come up against in clinical practice. And lastly, for the patient that's on antiplatelet therapy who now develops a venous thromboembolism, we have a parallel figure very similar to that which we had for atrial fibrillation that walks individuals through the process of how you make decisions around combination antiplatelet and anticoagulant therapy, and further break this down at the bottom of whether or not those individuals had venous thromboembolism that's associated with cancer or not associated with cancer, as the choice of anticoagulant and the duration may in fact differ in these populations. So overall, while there are a lot of flow diagrams and it covers a lot of different topics, and on behalf of all of my colleagues involved in the writing group, we very much hope that this type of document is useful in guiding clinicians in the outpatient setting and in the inpatient setting in figuring out the right combination of antiplatelet and anticoagulant therapy for the patients that you care for. Thank you so much. Hope this was helpful, and please be safe.